Here's Lesson B for EMS 260, the Trauma Cases course. We're going to talk about BP control in the normal setting and then in the very abnormal setting of neurogenic shock. Talk about the pathophys as a background for neurogenic shock, assessment and treatment of neurogenic shock. So it's really a neurogenic shock centered lesson, but we need to preface this with some review and more discussion about blood pressure. There's really three factors that go into determining your blood pressure. Two of them are cardiac output. What is the heart rate? What is the stroke volume? If the heart rate is too slow, the stroke volume would have to be quite high in order to have normal cardiac output. If the heart rate is too fast, then it may be beating too fast to even fill appropriately, and that's going to cause a reduced stroke volume. Or maybe you have something causing you reduced stroke volume, maybe multiple MIs, maybe some cardiomyopathy, or maybe there's something wrong with your ventricle and why it can't pump. Maybe it's a short-term thing like secondary to a sepsis event. Maybe it's a long-term thing secondary to congestive heart failure. Either way, heart rate and stroke volume are the two parts of cardiac output and two of the three parts of what goes into determining blood pressure. The third one is the one that's really the key for this lesson, called SVR, systemic vascular resistance. How much vasoconstriction is involved? How clamped down are the arteries and arterioles? How much afterload is involved? So we would normally have some peripheral vasoconstriction, not completely cranked down, but not completely relaxed. The normal state is partial constriction. That gives you normal SVR. But in the case of a distributive shock, then you have abnormal SVR. When vasodilation happens, as in the distributive shocks, whether that be anaphylaxis or neurogenic shock or sepsis, when vasodilation happens, now your SVR drops. So thinking back to the previous slide, if your SVR drops, then your cardiac output's got to go up to compensate. And usually it can. Usually it can go up to compensate. Heart rate can go up, stroke volume can go up, overall cardiac output can increase and accommodate that abnormally low SVR. However, that requires that the neurosystem, the brain, is able to sense that reduced blood pressure and able to send commands that get through to do the compensatory stuff, to have the increased heart rate, the increased stroke volume. However, if the brain can't sense the reduced BP or the signals that the brain is sending for that sympathetic response, that increased heart rate and increased stroke volume, that positive chronotropy and positive inotropy, if those messages don't get through, then cardiac output does not go up and the BP has to drop. And that's the problem with distributive shock. So the spinal cord plays a role in your BP management. It plays a role in determining the patient's BP. The spinal cord carries info from the BP sensors to the brain to allow the brain to determine that pressure is low, and the cord carries commands back down the sympathetic chain to increase heart rate in that whole sympathetic side of the response. The problem with spinal cord injuries in many cases is that the parasympathetic nervous system remains intact and is operating and is slowing the heart rate. But the sympathetic is not there to counteract it or overcome it. So you have unopposed vagal activity and you end up with bradycardia, which then, of course, drops your cardiac output. So now you have SVR dropping because there's no command getting through to the blood vessels to say, stay partially constricted. And vessels, when they don't have a command to do something, they just relax. So when the vessels dilate because there's no one telling them to stay constricted, and the heart doesn't know to speed up, then you have a drop in cardiac output and you have a drop in SVR, and that causes a drop in BP. So neurogenic shock is one of the three distributive shocks. It results from inappropriate vasodilation. The container is too large. And that's because of a loss of command and control from the brain. So it's a neurological system problem that's causing us a cardiovascular system problem. This is not traumatic brain injury. And so, yes, it's true that some elements of traumatic brain injury and neurocatastrophes, can be linked to neurogenic, but that's not what we're talking about. And a lot of students, paramedic students, get this confused easily. So neurogenic shock and a neurocatastrophe from a traumatic brain injury or a massive stroke, two different things. So where does this come from? Well, the bones in your spinal column may or may not be injured. The cord is injured. Now, one way to injure your cord is to injure your spinal column and have the bones impacting or impeding or compressing, impinging in some way the spinal cord. But you can have just direct cord trauma without a lot of bony trauma. In our assessment, we should palpate for and look for, feel for step-offs and unevenness, abnormalities, deformities in the spinal column, certainly. But the absence of those does not let you rule out spinal cord injury just because you can't feel a problem with the spinal column. Sometimes the cord impingement or compression is temporary. It's just due to swelling. Sometimes it's permanent. Signs and symptoms of neurogenic shock are different from hypovolemic shock. And we tend to really pound into your head the signs of shock. And so you say altered mental status, tachycardia, which is not present in neurogenic shock, cool, pale, clammy skin, which is not present all over in neurogenic shock. And so these differ. And then in a minute, we're going to say, oh, but wait, you can have them both at the same time. So, nothing's simple. Medicine's gray. It's different from hypovolemic shock because the compensatory mechanism that produces the typical signs of shock isn't in play. You don't have that sympathetic response to get you the vasoconstriction that gives you cool, pale, clammy skin. You don't have that sympathetic response that gives you tachycardia. The brain is sending the message, but the message isn't getting through. So the heart rate will not be elevated and frequently be actually bradycardic in the 40s and 50s when you were thinking that you're a patient with no radial pulse in a trauma should have a heart rate of 130 or 140. It turns out his heart rate's half of that or less in 50. And so that number should stand out to you and should clue you in to say, I wonder if this is neurogenic shock as well. The other interesting thing is the skin changes. As long as the spinal cord is intact, the skin that is innervated at that level of the cord will still get cool, pale, and clammy. So above the injury, you've got cool, pale, and clammy. Below the injury, you do not have cool, pale, and clammy. You tend to have warm and flushed skin. So there's almost a line on patients that corresponds to what level they're injured at. And so you're not going to have the typical shock signs of cool, pale, clammy skin below the injury. So I use the term dermatome in there. So here's dermatomes. And you can find lots of these on the internet and in PHTLS books and all kinds of things. Typically, the things that I would point out would be that if you have a sensation and normal response from the nipple line up, then you're looking at an injury somewhere in the T4 range. If you have sensation and you have normal cool, pale, clammy skin above the belly button, you're looking at an injury somewhere in the T10 range. Those are kind of the typical questions that you may run into on some written exam. But take a peek at this. It's not exactly linear. Particularly look at the anterior surface of the arms, and you can see how that T1 dermatome goes all the way down the center of the arm, and yet the medial and lateral aspects of the arm are innervated at different levels. So this is for background information, and really appreciate them putting an actual face of a guy up there. That's not me, but I just thought that was interesting. Anyway, there can be multiple causes as well. So, patients don't read our textbooks, they don't follow our protocols, and they have the absolute audacity to have more than one thing wrong with them at a time. They may have hypovolemic shock as well as neurogenic shock. They may have obstructive shock as well as neurogenic shock. A guy that gets pitched off a motorcycle is going to have some bleeding, may have a chest injury that causes him a cardiac tamponade or a tension pneumo, and he could also have neurogenic shock from the spinal cord injury. These can be complicated patients, but the good news is that in the field setting, your assessment's the same, and the treatment is based on let's go fast and get as much good stuff done as we can. Trauma patients get better in trauma centers, not in the back of ambulances. So we need to do a quick assessment and get moving. What do you do about a distributive shock? When the container is too large, well, logically, you could fill it up with fluid or blood, or you could try to shrink it down with alpha agonist, vasopressors. Some good ones are norepinephrine, levofed, same thing, dopamine at higher dose levels, and epinephrine. So you have some options. What do you do first? We almost always fill up the container first and then add a pressor in secondly. So Lab B prep, we're going to do several cases. The big main take-home points again, your brain and spinal cord have a role in BP management. The neurological system controls the cardiovascular system. And so an intact brain and spinal cord are key in order to maintain normal BP. Cardiac output times SVR, the brain and spinal cord are absolutely in control of the SVR piece of that. Your neurogenic shock assessment may be a little different. You may end up with a strangely low heart rate, lower than you would expect or actually even bradycardic. You may end up with cool pale clammy skin on part of your patient and not on other parts of your patient. If you think back to that dermatome map, you may have cool pale clammy skin on one part of the arm and not on the other part of the arm. So neurogenic shock assessment requires that you pay attention and be aware, be on guard for this sort of thing. Your neurogenic shock management is let's get going, which is different than let's go crazy with our hair on fire. We need to get moving. And then either fill up the container or shrink it down or both, but let's start with filling it up. And then let's also look for obstructive shock and relieve that if you can. So relieve that tension pneumo with needle chest decompression or something better. Try to deal with that hypovolemic shock as best you can. Control external bleeding. Do what you can to find and limit internal bleeding. Some good splinting helps there in many cases. Try to replace the lost volume with all we've got is crystalloids. If you have blood, that would be awesome. Blood is better. So these can be overlapping sorts of situations. Scenario number one, guy fell off a roof, has a palpable deformity, a step off in his thoracic and lumbar spine. He's got some associated extremity fractures, but this just happened and you had a short response time. So he hasn't been down for a long time, and his fractures don't really add up to severe hypotension this quickly. And so really you've got a neurogenic shock problem, some vascular access, on the move, fill up the container, and move on. Scenario number two is a guy in a tree. He fell from a tree stand, has a spinal column step off, same sort of problem, but he had a long downtime. So think maybe hunting season, deer hunter in a stand, fell, nobody found him for a while, so a couple hours have gone by. So now his extremity fractures have had time to bleed, and the hypovolemia is an issue, but he's also got that neurogenic shock problem. So what do? Fill up the container, which also is hopefully replacing some volume, and you may need to add a vasopressor to shrink it down. Same deal now, only now we add in some more of the real world. Maybe his glucose is low, his alcohol is high, maybe his body temp is low, maybe he's got some rib fractures, so maybe there's some obstructive shock. So this is actually a pretty complicated trauma patient. And how do you deal with complicated trauma patients? With a great assessment and fast treatment. And then this last one, I actually ran this call not too long ago and ran this call while I was developing this lesson. And so we're going to put it in here. And it may be a little bit over your head because if we start getting into tension pneumos and stuff, that's probably a lesson ahead of where we want to be right now. But anyway, guy's sitting in the pickup truck in front of his house. Female companion was arguing with him, also in the front seat of the truck. She pulls out a gun and shoots him. And he has a relatively boring, not bleeding very much, single gunshot wound in his right upper arm. But the important thing is that there was a lateral pathway. The angle of the shot was across him. The bullet went through and got both of the apices, the apex, the top of the lungs, and his spinal cord. Of course, he was also acutely intoxicated, just to make it more interesting. But this guy did not have tachycardia. He had bradycardia. He was not cool, pale, and clammy. And he was way too shocky for a very small and seemingly simple bullet wound that wasn't bleeding. So why wasn't it bleeding? Because his pressure was so low that it wasn't bleeding. So just try to bring this up to you because I felt bad that I didn't really appreciate the angle of the shot and include that into my assessment and pass that along to the trauma team. I saw a small gunshot wound in the arm and really drunk guy. And then as the medics were there, we were trying to get moving quickly. It became obvious that he couldn't hold himself up and really didn't have any sensation. Then it really started to become obvious. And the treatment for this guy included volume replacement, and they had to move very early on in his treatment to adding vasopressors. He ended up with dopamine in addition to wide open fluids to try to fix this. So anyway, here's 2 or 3 or 4 scenarios we're going to run, and all of these are real world, and this will hopefully help you solidify all this stuff in your brain. So think this stuff through, prep for these scenarios, and we'll see you in Lab B.